Can you guys, are you guys able to see this thing that I'm moving around or no?
No, we can't see it.
I just want to make sure they can't see the Zoom thing on the bottom. All right.
I see it.
Which one? The one that says the one that says participants 12?
No, the COVID, your PowerPoint.
Okay, good. Yeah, okay, perfect. You don't see it on your side. Perfect. Good. All right. So we're going to be talking about COVID-19 clinical update and management. This should be up to date as of April 14th, 2020. So just kind of knowing that, prefacing that if you're watching this in a video later on, that data and information about COVID-19 is coming rapidly on a daily basis, and we can all account for that. So if you're watching this 10 years from now, if it's April of 2030, you're going to be like, man, that guy had so many things wrong. And that may be the case, but this is up to date for today. Casey, see it. All right, so sound the alarm. As far as we know, there's some doubt about this, but the Chinese informed the World Health Organization on December 31st, 2019. There's no doubt that they did inform WHO on the 31st of 2019, but there's some speculation now that the Chinese may have known about COVID and about human-to-human transmission of COVID probably into late November or maybe the first couple weeks of December. This is kind of like just giving us a timeline. So we're talking about, we're 4.5 months at this point from what we all understand as the beginning. On the 31st, it was an epidemic, and it wasn't long until it became a pandemic. And so we're 4.5 months removed away from the first pandemic in our life, right? I guess H1N1 was a pandemic, but this is a real pandemic. January 31st, Italy records its first positive. It was a Chinese vacationer in Rome. By the 21st of February, so 3 weeks later, Lombardy reports a cluster of Italians that are showing up. The first one was actually a young man, I believe he was like in his 30s or in his 20s, that showed up like profoundly hypoxic. And they realized that COVID-19 had hit the center of Europe. On the same date, there were 14 confirmed U.S. cases, no deaths at that point. This is a screenshot from Johns Hopkins. This is current. This is today. You can see that this was clicked on for the United States. There are currently nearly 600,000 confirmed COVID cases with over 25,000 deaths. So this is something that's rapidly moving, novel, and we're still discovering and learning a lot about it. So COVID-19 clinical presentation. This is one of the first published reports that came out of Wuhan, and what they did was basically were describing the case presentation of the first wave of patients that they were seeing in Wuhan, and they clearly were hit with a surge. This is something that they were not prepared for. This is something that I think all of us, as scary as this all seems for all of us, that we've got at least a little jump. We're at least planning and preparing for surges, talking about the ethical dilemmas of providing mechanical support or life-saving intervention for some, but not for others. So they actually just trounced immediately. So this is some of the first reports of the patients they were seeing. So 81% of their patients had mild disease. So either they didn't have pneumonia or they only had mild pneumonia. So maybe they had an infiltrate in one lobe. They seen severe disease in 14% of their patients. These were mostly adults. I think there was only one known infant in China with COVID positive. So it is an adult disease at this point. So severe disease defined as respiratory rate over 30, hypoxic, right? So the Berlin definition of PF ratio of under 300, which we'll talk a little bit more about. Sorry, Jenny. She was in the waiting room there.
Mark, pinch the screen. There you go. Got it.
That's funny. In these patients that were considered severe disease, these patients had over 50% lung infiltrates within a 2-day period. And then on their critical disease, they reported 5%. 5% of their patients that were COVID positive actually presented with respiratory failure, septic shock, and multi-organ dysfunction and failure. This is kind of holding up. This is kind of what we've seen and the world has seen also. So these reports, these first early reports out of China are actually holding up to be quite true. All right, so this is a report that came out, I believe, on the 6th of April. And this was reporting retrospective data information on baseline characteristics and outcomes of about 1,600 patients that were admitted to ICUs in Lombardy, Italy. 99% of those patients with critical illness required respiratory support, whether that was considered non-invasive or high-flow nasal cannula in their non-invasive group or invasive group requiring endotracheal intubation and mechanical ventilation. They are reporting an ICU mortality of 26%. Is anybody hearing anything out there? There's been some really kind of crazy reports, not coming from peer-reviewed data, about the mortality rate in New York currently. Anybody want to comment on that? If nobody has heard of it, I won't mention it. Okay, so Lombardy's reporting an ICU mortality rate of about 26%. That kind of really holds up to be accurate as far as all the survival data that we know about patients that present with moderate to severe ARDS and require mechanical ventilation. So I would say hats off to them. It seems like they did a fantastic job and continue to do a fantastic job. So median PEEP on their patients were 14. 89. None of this stuff should be shocking, right? Nearly 90% of their patients required FiO2 over 50%. With a mean PF ratio of 160. So according to the Berlin definition, these are moderate ARDS cases nearing severe. They proned about a quarter of their patients, ECMO and 1%. Hypertension and diabetes ended up being the two biggest predictors of mortality based on like comorbid conditions. Questions, comments? It's kind of stuff that we've heard. So let's kind of just really quickly go over the Berlin definition of ARDS. This is like the world accepted definition at this point, an inflammatory process that ends up filling up the lungs with this protein-rich edema fluid. It's non-hydrostatic protein-rich pulmonary edema, so that means it's pulmonary edema that doesn't come from the type of like that you would see in a CHF exacerbation. That this type of fluid, if you were to actually examine it, would be extremely protein-rich. So that's the very early stages of ARDS, the exudative stages. So severe inflammatory injury sustained to the alveolar and capillary membranes. This is where we come up with diffusion issues with getting oxygen into the system and getting CO2 out. With your type 2 cells being overrun with edema and inflammatory processes, you get a surfactant washout and you get atelectasis and collapse. The Berlin definition requires that the processes that occur within the lungs happen within 7 days of a known clinical insult. So a vast majority of patients that have ARDS, it comes from a pneumonia, whether that's a viral or bacterial pneumonia. Over 70% of patients with ARDS, it starts out with a pneumonia. Anybody else want to chime in? What are the other two major factors or injuries that can lead to ARDS? So pneumonia is the big one. Anybody? Somebody? I'll call on somebody. Anybody want to chime in? Even a guess. Let's just be safe about it.
Sepsis?
Yeah, sepsis. Yeah, very good. Sepsis. And then one more. And these are all things that if you're working with patients and they come in and they have a known history of pneumonia, or you're getting your patient and it's being handed off as, hey, this patient has sepsis. These are all things that we should think about to say, what is my ventilation strategy? Does my patient have ARDS? Is my patient a candidate to get ARDS? And what are we doing to protect the lungs? And in general, what type of support are we providing this patient to give them the best evidence-based support that will lead to decreased mortality. So we got 2 of them. So pneumonia and sepsis and aspiration. So that's the 3rd one. It kind of goes along with pneumonia, but they separate it out. So the Berlin definition, it basically breaks down. So it removed what we were talking about with ALI. So you just talk about all of it being ARDS. And if your PF ratio is under 300, you have ARDS, but they call it mild. Under 200 to 100 is moderate, and under 100, is obviously considered severe ARDS. So that typically would be somebody on 100% oxygen with a PaO2 of under 100, right? So these patients are clearly sick and would have really, really increased oxygen indexes also, right? But we don't talk about OI often in adults, but OI happens to be the biggest indicator of mortality in ARDS. So this study came out, I believe this is 16, and they looked at data from around the world of patients that had ARDS or were diagnosed with ARDS, or that they missed the diagnosis of ARDS. So they looked at 29,000 patients. Was off because this is covering up our screen here. What they found was that in patients, when they looked at this stuff retrospectively, that they realized that over 40% of patients that had ARDS went unrecognized. So if you don't even recognize that your patient has ARDS, you're not thinking about taking a low tidal volume and evidence-based approach to lung protective strategy. And we know since 2000, since the ARMA trial came out, looking at low tidal volume strategy, and mind you, they were using, as a comparison, they were using 12 mLs per kilogram. They decreased overall ARDS mortality by 30%. So even still in this day, even with all the type of advancements we've had in management of patients with ARDS, we still have a mortality rate that is above 30%. So there's a lot to and the most recent studied ARDS intervention that showed a decrease in mortality. In fact, it cut it in half. We'll just sit here quietly, look at each other. What do you guys think? No, I mean, you're still mute. You want to talk? You're on mute.
Your audio kicked out.
My audio kicked out?
Yeah. We didn't hear the question.
Okay. You can hear me now, though.
Yeah.
What is the most what intervention was studied what was the last major publication that came out about ARDS that showed a decrease in mortality? Yeah. Who said that? Yeah, proning, exactly. So that study came out of France, and they decreased mortality in ARDS patients, and they looked at, hey, Peyton, how are you? Was that Peyton that said that?
Yes.
We got to get a position for her. All right. All right. So when they looked at proning, they looked at ARDS patients, and they just into proning or not proning, and all of them used the same ventilator strategy. So with standard ARDSnet, with your standard PEEP FiO2 titration, and they compared to that they proned. Peyton, do you remember what now that you've the answer? And I think you did a fantastic job at that. Not only did we talk about decreasing mortality in ARDS to 16% with the use of early proning, but do you want to remember the caveat of what kind of proning? How did they address proning?
Like the time.
Yeah, exactly. Yeah, what was that?
I think it was like over 60
Yeah, very
hours.
good. Fantastic. Yeah, we'll definitely have to get her a position. All right. So, yes, so 16 hours prone, 8 hours supinated position. So, yeah, very good. So long periods of proning and early proning intervention. So, you're talking about once your patients are having ischemia and your FiO2 is getting somewhere 60, 70%, you should think about proning your patients. Pretty well tolerated, and we do a fantastic job at it, right? So it's one of those things I think is one of the interventions that people are utilizing in COVID. So back to this lung safe study. They looked at 29,000 patients around the world in different ICUs, and they recognized that 40% of all patients had ARDS and it was not recognized. They also noted that there was a high mortality in the patients that did have ARDS at 40%. And they concluded that these high mortalities were, these are the things they noted. There was poor reporting of plateau pressures, that 33% of the patients received tidal volumes that were greater than 8 mLs per kilogram, and a large portion of their patients, 80% of their patients, received suboptimal PEEP, defined by what ARDSNet would say you should be according to the PEEP FiO2 scale. Johnson, welcome in. Sorry about that. Any questions about that? Concerns? What? And this is like for everybody who's seasoned, right? What kind of plateau pressures are we interested in keeping ARDSNet patients? Where are we interested in keeping their plateau pressures? Anybody?
Under 30?
Yeah, 30.
Below 30.
Yeah, and so that's right. So under 30. And is Jimmy online? I don't know if Jimmy's online or not. But we know that if you're in pressure control, what are we doing with that? So if, let's say, you're managing your patients with pressure control, so you're not using volume control, where you do a traditional inspiratory pause and you look at a state of no flow, right? And you're able to look at pressure under a state of no flow. So if you're in pressure control, how do you judge where you're at with that, as far as plateau pressures?
Your plateau pressure is near your peak pressure.
Yeah, very good. Yeah, and this is something that we actually did a little bit, led by Jimmy. They did a little study in the MI where they took patients that were in pressure control, they put them into volume control, and they looked at the relative plateau pressure versus peak pressure, and they found that they were exactly the same. Now the caveat is, if you're using pressure control inspiratory times that are really short, that may not hold up to be necessarily true. In order to have a pressure control setting, a total peak pressure setting that would average your volume control plateau pressure, you need at least four time constants. So you need enough time to overcome air resistance and to start distributing volume adequately to actually say that probably is your plateau pressure. Most adults, it depends on where they're at with air resistance and compliance, but most adults, somewhere around 0.8 seconds is usually reasonable enough to call it good. All right, so once your patient we've defined that your patient has ARDS. What is a definition of ARDS? So we talked about it earlier with the Berlin definition. So it's this PF ratio. What else would be something of interest to us?
Pulmonary infiltrate.
So ground glass appearance, right? So the Berlin definition, they basically talk about that it doesn't necessarily need to be bilateral, that you can actually have unilateral infiltrates and still be considered ARDS. But yeah, there needs to be imaging. There used to be a real focus on pulmonary artery pressures and whatnot, and poor LV dysfunction. But they found that a lot of patients that came in that had CHF that also developed ARDS were being undersupported with a ventilator due to their CHF background. So it's one of the things that one of the recommendations now is just to approach and treat everybody like they need lung protection. All right. Good. Any comments on that? No? Okay. All right. So what we have here will be the suggestion on any COVID patient that would qualify to be considered ARDS. All right. I hear chatter.
What was the question? Can you repeat the question, please?
Sorry. Yeah. I was more than anything, I was making a statement about the use of ARDSNet to treat our COVID patients. It's the best data that we have to date. It's the best way that we know to ventilate our patients in a safe manner and to reduce mortality. So not much has changed. And we know that COVID's novel, and we know that it's rapidly moving across the entire planet. And there has been a lot of talk about the way in which to approach the management of patients with COVID-19, which we're going to talk about later. But before we talk about later, we want to talk about what is the best evidence. What is the best evidence that we know in supporting patients that have ARDS? Somebody want to chime in. So once your patient has let's say they have ARDS, you've recognized it. What's the first thing you want to do to get somebody set up on ARDSnet?
Find their ideal body weight.
All right. So it starts with a good quality measurement, right? Then you plug them in.
Have their actual height, not guess.
Yeah, exactly. Yeah. So then you plug them in down into here where it says part 1, right? And then you get your grid out and it will show you your tidal volumes, or you can, once you have your ideal body weight, then you know that you can start at, where would you start at? What's that, Chris? From the very beginning?
4 to 6.
No, you can start at 8. You can start at 8 and walk down.
So the way in which ARDSnet was actually designed is to actually start your patient off once you're transitioning from conventional ventilation mode, whatever you're doing, you're recognizing that you have ARDS and you want to institute ARDSnet protocol. You actually start at 8 mLs per kilogram. Now, if your patient already has tidal volumes that are under 8 mLs per kilogram, nobody would suggest that you increase their tidal volumes. It's simply saying that if you are using tidal volumes of like 8.5 or 9 mLs per kilogram, and you now want to enroll your patient into ARDSnet settings, that your initial tidal volume set would be 8 mLs per kilogram. Can you guys think about what are some of the benefits of that? What would be the benefits of putting them in 8 versus just putting them in 6 right away?
You can have lower rate, then you're not on such high rates, and you can keep the eye time pretty stable, not so low yet.
Yeah, and the other thing too is with that transition, you're not going to leave them in 8 mLs per kilogram long, right? It's an hour and a half, 2 hour period. More than anything, you're giving your nursing staff and your physician staff time to get your patient adequately sedated to be able to be managed with low tidal volumes. Hey, we've all managed patients with 6 mLs. They don't necessarily like it. And if you're utilizing straight assist control, volume control ventilation, you'll know that if you're using VC and you are at 6 mLs per kilogram and your patient tries to draw a larger breath, they'll actually stack a breath, right? So as you work your way down from 8 down to 7, you can, like Naomi said, now you can increase your respiratory rate overall, and you start looking for dyspnea and air hunger from your patient as you're starting to lower your tidal volume down. So it allows your nursing staff to get your patient adequately sedated to actually tolerate dealing with 6 mLs per kilogram. And you're allowed, and don't forget, you're allowed to run your respiratory rate all the way up to 35 on ARDSnet, and you can run your IE ratios at a 1-to-1 ratio. All right. What they do know, that there often is an underappreciated amount of auto PEEP in ARDSnet patients. It can be pretty drastic, actually. But it's one of those things that there may be some benefit to that auto PEEP anyway. So don't be scared of IE ratios that are 1-to-1 in your true ARDS patients, and utilize the ability to lower your tidal volumes down incrementally, 8 to 7 to 6, because when they looked at the original ARMA trial, they looked at patients that were on 12 mLs per kilogram and patients that were on 6 mLs per kilogram. And qualitatively, they both received the same amount of paralytics, and they both received the same amount of sedative agents like midazolam and Versed. But when they looked at quantitative, the patients that were on lower tidal volume required a lot more of those drugs. So that's one of the things we do know. And if you're going to try to get your patient into a quiet state, it's easier to go 8, 7, 6. All right. So give you time to get some more sedation on board and allow for ventilator synchrony. Any questions about that? And remember, during ARDSnet, you're allowed to run your patients down to 725. So don't forget that it's permissive hypercarbia and permissive hypocapnia, hypercarbia and hypoxia. All right. So permissive on both. Any questions, comments?
Yeah, did you say 725 or 715?
725. Oh, it may have changed. Did it change?
I thought it was 715.
As far as I know, 725. We can check on it. There may have been an update that I'm not familiar with.
Nebraska, we did that study.
What's that?
We are good.
Okay.
Thank you.
All right. So now that we've gone over the best known evidence, that cut out, didn't it? Uh-oh. So now that we've gone over the best known evidence for treating patients with COVID-19 ARDS, we're going to talk about what the recommendations are from the Surviving Sepsis Campaign. This is going to deal with our patients that present. Specifically, we're talking about patients that present with refractory hypoxemia, but may not be showing some of the other signs of ARDS. So they might have decreased PF ratios under 300, but these patients may be silently hypoxic. There are reports out there that patients aren't, I don't think a large portion of them are presenting this manner, but the patients are actually coming in and they're profoundly hypoxic, even though they don't have this giant increased work of breathing. So we're going to be talking about what the current recommendations from the Surviving Sepsis Campaign is and the quality of evidence. So supplemental oxygen to keep your patients above 90%. So in between 90 and 96%. So there's some moderate evidence that suggests that that's beneficial. High flow is suggested over conventional oxygen therapy. That's a weak recommendation, but if you read the ARC's high flow nasal cannula year in review, there's a lot of benefit to high flow nasal cannula. What is some of the downfall of using high flow on our COVID patients?
They're always AGP.
They're always what?
Yeah. AGP.
Yeah, exactly. So there's the concern. So everybody's initial response to treating COVID patients came from Chinese suggestions on what they did, and that suggestion came as a way of decreasing transmission. You got to remember this was a rapidly, by the time that Wuhan had first reported, I mean within a month they had 70,000 patients with COVID-19. So these suggestions early were more about transmission than they were about the efficacy of treating hypoxia. So now we're ahead of it. So if you've got a patient who comes in who's suspected COVID, and they are just presenting with hypoxia, and you can get them isolated, these are the suggestions that are coming from Surviving Sepsis Campaign. That the use of high flow non-invasive oxygen devices is definitely worth a chance. We got a patient now that's in MICU that's been there for several weeks that's been on and off of high flow. So that guy, I believe as of yesterday, he was completely off of high flow. But if we would have taken the recommendations as of like 3.5 months ago, we would have intubated him, and who knows how that would have gone with mechanical ventilation. So even the use of NIPBV, it's a weak recommendation. But again, if you have a patient that comes in with refractory hypoxemia, there is a weak suggestion, a weak quality of evidence suggestion that NIPBV is worth a trial. One of the things that I think what we should be really concerned with the use of NIPBV is that going into it, we really want to watch our patients' work or breathing. If you're going to institute non-invasive ventilation with these patients, we really want to take a good look at them. We want to keep, if their respiratory rates start to creep up, they start to becoming rapid and shallow on us, we want to probably abandon the non-invasive plan and probably just move towards intubation. So we know the patients at the highest risk for the use of NIPBV are patients that present with PF ratios that are under 200. Has anybody working up on Davis 14? These are probably the patients we're talking about. Can anybody talk to what we're actually seeing at the bedside with these patients that are hypoxic and their work of breathing? Chris was pointing at you, Fareed.
I had patients in Davis 14 the last couple of days, but I did not come across patients that they were hypoxic or hypoxemic. Most of them were on room air, but 1 or 2 patients on 2 to 4 liters of nasal.
Okay.
There's a gallon gold on high flow.
Yeah, we had a patient in MI that was on high flow also. So these are the patients that are coming in that we're saying, yes, there's a chance that you can treat them with NIPBV. But if we're going to go down that road, there needs to be a lot of communication between us and the medical staff and saying, what are our expectations? Let's find at the very beginning of this, what does NIPBV failure look like? what patient presentation are we now willing to abandon NIPV and say we gave it a good college try? And we want to talk about why it could be so detrimental to be left spontaneously breathing with evolving severe ARDS. What happens when these patients are having these large inspiratory demands? So this is what the data is starting to suggest, that these COVID patients that are coming in that are hypoxic, but don't necessarily have really high increased work of breathing, aren't having ventilation issues at all, that there may be some perfusion, there may be some DIC and some perfusion issues in the lung, where these patients are overcoming it by breathing in large tidal volumes. They don't have increased work of breathing, but they're doing larger volumes, and there's probably clearly dead space and clearly shunting going on. So you can manage patients in that as long as the inflammatory process doesn't continue, the cascade doesn't start. And some patients respond to just using oxygen and will get better, and some patients will have that biphasic response that they're talking about with COVID and will just get worse on you. So if you're using an NIPPV on your patients, one of the things I really would like to talk about with increased work of breathing, especially with lung injury, is if you're using non-invasive, don't be scared of your EPAP. If you don't want patients having to overcome and reopen up and expand alveoli from atelectasis every time they take an inspiration. They're going to cause themselves stress injury. You're going to have giant swings in transpulmonary pressure. They can pull so hard with their diaphragms that they can actually cause a lot of damage at the capillary bed and cause negative pressure pulmonary edema in certain areas. They can have so much negative intratranspulmonary pressure in certain areas that they can get this concept called the Pendeluft, where you get this. It's named after the pendulum swing, and Luft, as in Lufthansa in German. You get this, they call it swinging air. So you can create a tremendous amount of negative in one area that can actually pull volume out of other areas. So you can get atelectasis in that area, then you can get overdistension in the area that has a lot of negative pressure. So all those things have to be thought about when you're managing patients on non-invasive. And the way to do that is to properly support them. Don't put patients on vanilla IPAP and EPAP settings. Don't have somebody coming in that's really working hard, that's having a lot of work of breathing, that's huffing and puffing, that's rapid and shallow, and put them on 10/5. You're not doing the patient any benefit at all. Really try to meet their IPAP and EPAP demands by looking at your patient, just doing a really, really good patient assessment, all right? If your patient's being managed with NIPPV and starts looking bad, starts having increased work of breathing, you need to abandon that plan, right? So that's when you would probably want to intervene. Is there any questions about that? We're going to get to some good stuff, and I've got about 20 minutes here. Any interjection? Anybody had questions about that? All right, I talked a lot about that. All right, so I want to introduce this to you. And let's just make this very clear from this point on, all right? This conversation we're about to have from here on is discussing things. It's like academic masturbation, all right? This stuff may end up being really beneficial. This may end up being the things that guide us in the future, but let's make we're just having an academic conversation at this point, all right? This isn't coming from randomized controlled trials. And this information right here with the Gattinoni thing is expert opinion. Expert opinion, it is in a peer-reviewed journal. It just came out. But this is going around online. This is in the respiratory chat rooms. This is what our colleagues are talking about. And I know you guys have heard about this. But there is this theory about COVID-19 having phenotypes, all right? Phenotype L and phenotype H, where the L, they're saying that you have low elastance. So elastance is, you can consider that resistance, as in talking about like lung resistance. So you have low resistance to lung expansion. So these patients come in, they're hypoxic, but they have normal lung compliance. They're saying that they have low VQ, which here again, there are a lot of people out there that are really wanting Gattinoni to explain this. I personally, at this point, don't buy into this aspect if these phenotypes are accurate. But they're saying that they have low VQ, so fairly decent VQ. Low lung weight when they look on a CT scan. So if you see over here in Figure A, This is a patient right here that is COVID-19 positive. You can see their PF ratio is 95, right? So that's severe, according to the Berlin definition, severe to ARDS. They're spontaneously breathing, though. They're on a Venturi mask at 80% oxygen, and their total lung capacity is 4,200 mLs. So these are the patients that Gattinoni is concerned about, and I think we should all be concerned about. Because if you were to take this patient, patient A, who came in with refractory hypoxemia, and you were to say, let's intubate them, you would use ARDSNet on them, right? And in order to get, look at that PF ratio, right, of 95, so 80% oxygen. Does anybody, right off the top of your head, know what the PEEP FiO2 scale is? Let's say that patient was on, ARDSNet, and they had 80% oxygen requirement. What would their PEEP level be?
On the high PEEP level or the
Let's
low
just say
PEEP?
low PEEP. They're both high PEEPs, but
20?
yeah, it's somewhere up there. Yes, if I had to recall off the top of my head, done a lot of it. It's definitely above 16, right? And this is the argument that Gattinoni is making, and it's well taken, right? I think this is probably the reason why this patient is spontaneously breathing. But if this patient wasn't spontaneously breathing and required intubation and was put on ARDSNet, would this patient benefit from a PEEP of 16 or 18? Any thoughts? Come on, Mark, where are you at?
We say no.
Yeah, you say no?
We say
Yeah.
no.
Yeah, and so in Gattinoni's defense, I mean, this is what he's talking about, is that these patients that just are hypoxic, and they're at the very early stages of ARDS. If you were to do imaging on these patients, or like they've done here, you wouldn't have that bilateral ground glass opacities yet. It wouldn't look like your classic severe ARDS, even though it's presenting with the PF ratio aspect of it. And so what the argument is maybe we should try to treat these patients with non-invasive means. Then COVID-19 pneumonia, what they're suggesting is type H, and these are saying all the other stuff was low, all these are high. So they're saying this patient now has high elastance, right? So this patient has decreased gas volume, and they have really, really poor compliance, right? So you're not getting a lot of volume for the amount of pressure that you're having to use. They're saying these patients have high right to left shunt. I completely buy into that. A high lung weight, completely buy into that, right? You have to remember these patients have a lot of that protein-rich fluid socked in their lungs. They have a lot of surfactant washout. So yeah, these patients are going to have lungs that their lymphatic system isn't functioning. So they're going to be really, really wet. They're not going to facilitate gas exchange well. And they're going to be highly recruitable. And so you'll see that what they're calling type H is your patient, and this is what they're saying their settings were. A PEEP of 5, they were doing tidal volumes of 7.8 mLs per kilogram and 70% oxygen, and with a total TLC of 1360. Now, here again, I don't know why. I hope this isn't the way they were managing that patient, right? Because that patient, in this case, should probably be at 6 mLs per kilogram. With PEEP, that would be a lot higher. Would this patient right here respond to PEEP levels?
That type
Type B,
H?
yeah, type H, or what we're looking at imaging as far as B.
Heck yes.
Yeah, that's your classic.
Yes.
That CT scan on B is your classic. That is your classic severe ARDS imaging, right? You're going to have areas in the bases that are completely consolidated and probably are not recruitable. Remember, it's a heterogeneous disease process. You're going to have areas in here, right, that are probably somewhat recruitable, and then you have areas in your apices and your anterior areas that are probably just completely overdistended, right? So it could be, this is one of those things that we're going to discover, and maybe by next year we'll know whether there really are two phenotypes and which way, according to evidence, we should actually approach the management of these patients. Is there any questions about that? You guys have seen this before, I'm sure, or starting to hear about this. Geometry dude, you're looking bored. All right. So let's talk about the use of inhaled nitric oxide. This is coming from the NIH now. Crystal, myself, Michelle wanted to provide you guys with some information about things that are happening out there, how people are looking at treating COVID-19, it being a novel virus. People aren't really sure. But so INO has been shown to have antiviral activity. All the data, the only thing that I can find, I've got literature coming, the only thing I can find about its antiviral capability is that it actually somehow interrupts RNA replication. So besides that, I'm not well read on it. But they did use INO successfully during the SARS epidemic. It showed that they reversed pulmonary hypertension, improved severe hypoxia, and decreased the length of ventilator support. So, I mean, those are things that I think at this point would be hard to argue against. If your physician you got a patient on COVID-19 and they say, hey, let's try INO, I don't think there would be a lot to stand on to say no. We do know that in early ARDS studies, the use of inhaled nitric oxide did not do anything with mortality. So it didn't decrease mortality. So we've always been able to stand on this. But this being a coronavirus like SARS, I think it would be hard to argue at least not giving a trial. There is a study, ongoing study, Kasmerik's group in Boston, and they're looking for sites. But their study protocol with INO is looking at using 80 parts per million for the first 48 hours. It's pretty, I think it's pretty controversial. I'm just gonna say I think 80 parts per million can have all the negative effects of INO that we've all talked about. With hemoglobinemia, it can, depending on your minute ventilation, 80 parts per million can drive your FiO2 down by 10%. So these are, people are kind of like controversial about using 80 parts per million, but if the concept is that this stuff actually is in your airways, right? This is where this stuff is actually impacting us. That if you're using 80 parts per million for the first 48 hours during initial disease, that it may interrupt RNA replication and actually may dampen viral load. So that's kind of the thought. So
we've only been using 20.
Yeah, well, I've seen a patient on 30, and here again, we really want to talk about this is an ongoing clinical trial. So we're not saying that this is something we should be doing, but this is something that's being done, and we'll know next year. We really will know next year. I would be hesitant about this, to be honest with you, but it's one of those things. I'll remain open, and I think we should all remain open to see what the data actually shows. In that ventilator protocol with INO, 80 parts per million for 48 hours, and then they reduce it to 40 parts per million, and then they wean it after your PF ratio is greater than 300. An ongoing trial. All right. Oh, sorry, guys. Okay. So it's one of those pro-inflammatory cytokines. I know everybody's hearing about the cytokine storm. What they're finding in COVID patients is that nearly 3 times the higher levels in COVID patients, IL-6. IL-6 has always been known to be linked to adverse outcomes. It is the main mediator of respiratory failure, shock, and multi-organ dysfunction. All right. So 2 things that are being done here at UC Davis. These were study sites for 2 of them. The Tocilizumab. Don't laugh because you have to try saying that yourself. It is actually an IL-6 inhibitor. So what it does is it blocks downstream pro-inflammatory IL-6 effects. It's one of the things we're trying here. It is a drug that's actually being already FDA approved, not for COVID-19, but we're looking at it as an orphan drug. If drugs are actually already approved for use, they can become orphan drugs to be looked at for research pretty quickly with the FDA. I think that process is actually happening really quick. As far as I know, this stuff is being used in autoimmune disorders. So then we're also doing remdesivir. It's a broad spectrum antiviral drug. It's shown promise in animal models in MERS, which is also a coronavirus. And we are also an enrollment site for that. So kind of be looking out that these are the 2 things that we're actually doing with our COVID-19 patients here to participate in research and try to answer the questions on how best to manage the patient. Questions? Comments? Onward. All right. Now we're going to get into the nonsense, or what I'm going to say is nonsense. I know that we're all seeing stuff online. We're seeing things in newspapers, we're seeing things in blogs, and oftentimes we can find ourselves to be impressed by it, but I just really want it. We all just need to be on the same page that when we look at information about how best to manage COVID-19 patients, that we remain skeptical about the source, right? And I'm saying be skeptical about what I'm telling you too. Trust me, but then I want you to go verify the information that I've told you. I've given you the resources and the links to the things that this PowerPoint has been created with. Go and read the research yourself, right? So don't, have a skeptical way about what am I going to do? How am I going to approach my clinical practice? Our clinical practice needs to be based on evidence-based medicine, and it needs to come from things that are peer-reviewed. So this Facebook Dr. Peter Barrett, he puts this thing up. He suggests tidal volumes 8 and 9 mLs per kilogram. I don't see any references to that. He thinks you should probably go ahead and use hypertonic saline. And they've lost a couple of their ECMO patients, but other ones have been discharged. So this is anecdotal. This is not the things that you would want to take to the bedside and talk to a physician about and say, hey, I read this Facebook blog by this doctor in Piedmont Heart Institute. He said, he did do a whole number of 15 bronchoscopies. We know that you can tell a lot about lung injury from bronchoscopies. So this was from a Facebook thing that I found. I blocked the person's name out. It's nobody that works here. But this person has really been enamored by what she's been reading, right? We have reversed our strategy at KP. I imagine it's Kaiser Permanente, but I don't know. VQ mismatch and virus attachment to heme monoxide poisoning. Quickly proning patient on high flow nasal cannula. Worked on one patient for a few days, but we will see. Try to avoid intubation. APRV mode of choice, but most RTs aren't familiar. Anybody want to make a comment about this? These are the kind of things that are making me angry at times. These are the things I think that we're poorly representing our profession, quite honestly. Does anybody know what they're talking about with the heme and the carbon monoxide? We're going to go to the next slide. This just recently got debunked. We've been talking about it for over 10 days. It's a lot of the experts are finally weighing in on it. Thank goodness. Somebody speak up. Anybody see this? Has anybody heard the rumor that COVID-19 attacks your hemoglobin and disrupts its ability to carry oxygen by messing with the iron in your heme? Anybody heard that? No? Well, you guys aren't reading the same junk I'm reading, which is good.
I heard that.
Okay, thank you. Somebody heard that.
I heard it too.
Hey, and there's a lot, and people are really going crazy over this. You've seen that person's thing on Facebook. Oh, the heme thing and the carbon monoxide. People are just running with it, right? And and I was talking to somebody about this, and I was like, I don't know. This thing seems like this is the paper that people were using. This thing did not come out of a peer-reviewed journal. This is something that's floating around online. Who knows who wrote it? Who knows why they wrote it? Maybe it is an academic paper that's looking to get published, but in order to get published, you need to be peer-reviewed, right? That means experts in that field read through it. I'm not a virologist. I can't talk about positive strand RNA viruses and this and that, right? I'm not an expert about it. But what I do know when I see something like this, I remain skeptical first. I'm a skeptic. And then I go, well, is this in a peer-reviewed journal? It's not. Okay, well, then I wonder, it'd be interesting what somebody who's a hematologist would have to say about this. And when we created this, one of my biggest arguments was, if this is a hemoglobin issue, how come all the COVID-19 patient data that's coming out is following your normal oxygen hemoglobin dissociation curve? Meaning that if your patient in a COVID-19 patient has a PaO2 of 40, what do you think they're finding their SpO2 to be? '40s here. Come on, you guys know this one. This is with a PaO2 of 40. What is your SpO2 on a normal O2 hemoglobin dissociation curve? 75. Yeah. So think about your CTICU patients, right? Think about that's your mixed venous sat should be 75%, right? Which is a PVO2 of 40. All right. So if this case were true, that you had all this hemoglobin running around that couldn't carry oxygen, you would see high PaO2s, right? Because the PaO2 comes out of the plasma, and you would see saturations of hemoglobin that wouldn't be based on a normal oxygen hemoglobin dissociation curve. So if that were true, if this were an actual hemoglobin disorder, you would have a PaO2 of 100, but this curve would slide over to the right, and you would have a saturation of 80, right? Like you would see in carbon monoxide poisoning. We're not seeing it as. So remain skeptical when you're reading things, even though they look scientific. Remain skeptical. Evidence-based medicine, peer review.
Mostly don't get your sources from Facebook.
Yeah. Agreed. All right, so COVID-19 serology. This is something that the FDA approved 10 days ago. This is something that I'm excited about. This is something that I think we should all be thinking about. This serology report, surveillance serology especially, is going to be the one thing that really is going to guide us back to when our life can go back to normal. It's only approved for surveillance and for research surveillance right now. And the test that's actually in the United States that's approved is an RDT, is a rapid diagnostic test. It's just like a pregnancy test. It's a dip in some type of fluid, and then it's a blue line or a yellow line or something of that nature. It doesn't tell you about how much antibodies you have. It doesn't tell you what would they think you came into contact with COVID-19, how long ago. It just tells you, yep, they've got the antibodies that came from COVID-19. But this is one of those things that's rapid, meaning 30-minute wise. And when they start doing surveillance, hopefully the data that comes out of Stanford is doing some of this right now. And what we're hoping to see is that you want that number to be somewhere around 50% or more, right? If 50% of our population being surveilled has serology that's positive for COVID-19, we're working on building herd immunity. Some of the earliest reports, just yesterday, Germany does most of this. They're the most advanced with serology in the world. They're doing testing, and unfortunately, some of the preliminary stuff on their population is about 5%. I hope that doesn't come out in the United States because that'd be horrible. That means we're going to be doing this distancing thing for a long time. Other testing's coming online, and this is one of those things that we should be excited about. So serology. And that is it, you guys. I don't have any more for you. These are the references. Does anybody have any comments, some questions they want to talk about?
Where can we find your presentation? Is it
not yet? It's like we're actively recording now. But the plan is I'm gonna compress this thing and put it up on the UC Davis YouTube page. All right, and then I will send out another link to that, and then we can go. You'll have free access to it. All right. And these are all the references that were used for this presentation. So if you guys don't have anything else for me, you're welcome.
Thank you.
You're welcome.
Thanks, Brian. Bye, everybody.
Bye.
Bye.